First, I have to say that this is, it's an amazing honor, really, to be here. It's something that, meeting a lot of people that I've only read about, actually getting to shake the hands, realize that they're real people. And so that's remarkable. And so I have a bit of apprehension coming and giving this talk for two reasons. One is I'm not really an epidemiologist, although I have been broken down by sex and age. And the other reason is that I'm incredibly jet lagged. You've picked just the right time for the jet lag to hit, and so it's not a worry that the audience falls asleep during my talk. It's a worry that I do. If I start going off on a tangent, Roz, you've got a directive to get me back on track. So I'm going to talk in a focused way about one concept of disease and epidemiology, and that has to do with viruses and cancer. And hopefully I'll have something to say that will be at least, it won't have answers, but perhaps might have questions that you'll find interesting. And in particular, I'm interested in the ways that molecular biology and the new techniques in molecular biology, how they inform us in epidemiology. Now, because this is, of course, the Snow bicentennial, I wanted to show a chart, historical chart. I don't expect you to be able to read this, but just the idea of viruses causing cancer goes back well over 100 years. And so that there have been times when all cancers were thought to be caused by viruses, other times when no cancers were caused by viruses. Again, in the 70s, 60s, and 70s, things went up again and then went down again. But now we have a fairly clear idea that there are at least a fraction of human cancers that are really, truly caused by infection. Does that do it? This one. Sorry. Nope, this one. This is good. Sorry. And so now we have the sense that there are 7 well-defined viruses that cause human cancers. I'll be talking today about these last 2 because I think that they illustrate some interesting epidemiologic features, but also because I've been involved working on them, so I know them well. But other people in this room will be able to say exactly the same thing about other viruses and other cancers. I don't mean to imply that what I'm saying is particular to KS, HV, and Merkel cell polyomavirus. However, what is important, what is often lost, particularly by oncologists, is that 1 out of 5 cancer cases worldwide appears to be caused by infection. About 1 in 6 are caused by viruses. And that obviously that this has a potential, these cancers have a potential new diagnostic, a non-self-diagnostic, non-human diagnostic, and also potential for being able to specifically target the tumor by targeting the virus. So that's very important. So let's first talk about Capsu sarcoma. I think, as all of you know, Capsu sarcoma was a harbinger for the AIDS epidemic early on. Of course, the first reports were of this rare cancer occurring in gay and bisexual men. And the epidemiology of this tumor had a very unusual feature. This is actually graphs of just the rates of Capsu sarcoma among AIDS patients. This is prior to actually the identification of HIV. So the rates of Capsu sarcoma among different AIDS populations, what you can see is gay and bisexual men are about 10 to 15 times more likely to develop Capsu sarcoma than hemophilic men, even though both groups are equally infected with HIV and are equally immunocompromised and have other features of AIDS. And so this suggested that there is an exogenous factor that would be causing this tumor. And for those students who are here in the audience, this is a paper that you really, in fact, not just students, everyone, this is a paper that all of you should read. This is really a masterpiece in epidemiology, I think. This paper by Beryl and Jaffe. I think Val is here in the audience, at least she was earlier. Oh, there she is, up there. And so this is a brilliant paper because using this, the epidemiologic data, this group was able to show very precisely that there was an exogenous agent that was causing this cancer, that the cancer should be rare in the prevalence of this infection should be rare in the general population, should be sexually transmitted but poorly transmitted through blood transfusions or organ donation, and that the agent would be more common in Africa, less common in Mediterranean countries, and least common in North America and North Africa. And all of this turned out to be the case. In fact, I like to say that Farrell and co-workers actually discovered the cause of Capsu sarcoma. We just found out precisely what the virus was that was doing it. And here's a case where the epidemiology very, very nicely delineated the fundamental underlying cause, and I think that this should be used in schools of public health, and I'm sorry that it isn't used more often. But what we did was, because of this clear and compelling data that there was an infectious cause for this cancer, we used a technique, and this is Yuan Chang. She's my wife, and when Paul invited one of us to come and give the lecture here, we flipped a coin and you lost. So she could have given this lecture easily, just same as I could, probably better. We share our work together, and we're interchangeable in what we do. But for the most part. So we used a technique where we physically subtracted DNA from a Capsu sarcoma tumor using healthy tissue DNA from the same patient. That's important because the DNA has to be precisely the same, except for when it was subtracted, what was left was unique non-human DNA fragments that turned out to be less than 1% of the viral genome for this new herpes virus, KSHV or HHV8. And from that, we were then able to go on and try and identify what are the features of Capsu sarcoma to see and infection with this new virus to see if it fits defined criteria for causality. So this is Hill's list of, sorry, I'm working with this pointer and it's not doing so well, but this is the list of Hill's criteria for causality that, at least when I was in public health school, were considered the sine qua non for identifying causality. And what we see is that in this case, the association between KSHV and KS fit beautifully in every case, so that not only our group was able to see that virtually all KS tumors are infected with this virus, but other groups were able to see that. Not only is AIDS-associated KS positive for this virus, also KS that would be occurring in other settings, for instance, after transplants or after in African populations and so forth, all of them were positive for this virus. And going down this list, which all of you I'm certain have at least some familiarity with, all of it was quite easily identified as being true. And again, this was because the underlying epidemiology was so strong for this association. But how quickly, once we'd identified this piece of DNA, things could unfold, I think, is illustrated in this slide. So Capsu sarcoma was first described in 1873, I think, by Moritz Kaposi. And it was a complete mystery as to what the cause of this cancer was, how it occurred, who would be affected, who was at risk, up until the virus was found. And then at that point, when these two little bits of DNA, two little snippets of DNA were found, then rapidly, of course, we could extend the genome for the virus. We could identify that other forms of Capsu sarcoma were positive for the virus, including AIDS. We could also see that there was a rare lymphoma that was associated with KS that was KSHV positive. Use these cells to identify, isolate the virus in culture, identify the virus itself, and then make blood tests for the virus. All of this occurring within 2 years. The virus finally was sequenced. And this work, by the way, identifying the serologic test for this virus was done in collaboration with Robin Weiss, who I think was here. And much of the early work in this period was really boosted by Robin Weiss and Chris Boshoff, Thomas Schultz, and others who we've been collaborating with and been good friends with for years. So it's really nice to see these folks here. Until finally, let's go back. The whole genome was sequenced, and within 2 years, I think it was fairly clear to most people, not all people. Of course, there are many skirmishes and angry denunciations and insults and invectives during this period, but by 2 years, pretty much everyone who had a brain in their head realized that this virus was the cause of Capsu sarcoma. It fit the criteria, and it worked out quite nicely, so it was really good. So epidemiology works. You should be proud of yourselves. Now, what is the reasons for that? One reason is the low prevalence of KSHV in the general population, so we could make a comparison to see what the risk was for various populations. Secondly, what we found was that there was a high penetrance of disease among people who were infected and immunosuppressed. So those people who actually were exposed to the virus had a very good chance of developing the tumor outcome. And then finally, there's only one cause for Capsu sarcoma, and that's KSHV. So it's, in that sense, we're really quite lucky that the biology of this virus was such that we could easily fit these epidemiological principles and work them out. Now, with cancers that are caused by various infectious agents, this is a standardized incidence ratio chart from Andrew Grulich. What it shows is that among a wide variety of tumors that are associated with infection, what we see is that transplant patients are a much higher risk, above 1 here, much higher risk than patients who have other tumors that we have no indication are caused by an infectious etiology. For instance, general breast cancers or prostate cancer and so forth. And so we can use this as a tool to try and look for other cancers that might have a virus. And so Yuan and I decided to take a look at Merkel cell carcinoma, which is a tumor that's increased among immunosuppressed patients. This is a very aggressive, low molecular weight cytokeratin positive tumor, CK20 positive tumor. It occurs more commonly among the elderly as well. It actually, even though I had never really heard of this tumor when I was going to medical school and knew very little about it, it's actually not that uncommon a tumor. It causes about the same number of deaths in the United States each year as chronic myelogenous leukemia. I'm not certain what the rate is in England. But there has been a marked increase in at least the diagnosis of this tumor over the past 15 years, probably just because of awareness. But to some degree, it may be because of the aging of the U.S. population. There we go. Got to find the magic spot. So we used a new technique, new molecular biology technique, to try and find the virus in this. And so instead of physically subtracting DNA from one tumor and from the healthy tissue, what we thought we could do is sequence it. And this was work that was performed by 2 really brilliant postdocs in our lab, Wei-Chen Feng, Masa Shuda. What we looked at was 400,000 different sequences, cDNA sequences made from RNA from 4 tumors. So 400,000 different sequences. And then we simply identified those sequences that we had very high confidence were giving us precisely an accurate read. So they had a Phred score of 10 or higher in sequence speak. And the reason for that is because what we're going to do is align those sequences to known genomic databases, subtract out all of the human sequences. We're left with a pool of candidate sequences here that might be non-human. Here there's about a little over 0.5% of the sequences. And from that pool, then, we can open up our alignment filters and align them to viral databases and see if there's a sequence in there that looks like it belongs to a new virus. And in fact, we did that, found that there were 2 sequences out of the 400,000 sequences that belong to a new virus. That's a polyomavirus. Polyomaviruses, most of you are probably familiar with SV40, if you will, the workhorse for molecular biology. So this virus is closely related to SV40. It's a very simple virus, unlike the herpes viruses. Only has, depending on how you count them, about 4 genes, 5 genes. Half of the genes are structural genes here that make the capsid. We can use that to make ELISA tests. The other genes, this is actually one gene that's multiply spliced in different ways. It's called the T antigen. It's the oncogene for this virus. And we've seen that it transforms cells. So this virus has the features that we'd suggest might be likely to cause a tumor. However, this virus is nearly ubiquitous. Virtually all of us in this room are growing this virus in this room right now, probably transmitting it to each other as we sit here and speak, or at least while I speak and you listen. So how epidemiologically do we tease this out? And this is a very similar problem that stymied epidemiologists working on the first human tumor virus, EBV, associated with Burkitt's lymphoma, almost 50 years ago. So it turns out, I've got to point at something. I haven't figured out what I've got to point at yet. Any clues? Point at that. Okay. So this is a small circular DNA virus. And this is important to tell you because this has some epidemiologic impact. You'll bear with me. So this is a small circular virus. Normally it lives in the host cell, replicates in the host cell as a small circular virus. However, in tumors, it integrates into a host chromosome at a precise point. It can integrate anywhere within the host chromosome. Now, we can sequence these ends right here. Whoops. We can sequence the ends right here, know precisely where it's integrated in the host chromosome. And what we see in tumors that are caused by this virus, Merkel cell tumors that are caused by this virus, that the virus is clonal within every tumor. So in this case, the obvious implication here is that a nascent cell integrated the virus into the host genome at some point, and then every subsequent daughter cell from that clonal expansion will have that integration at one and only one site, as opposed to cases where we might have an integration event, but it isn't related to the actual causation of this tumor. Then we'll have, of course, a variety of integration events within the tumor, but it won't be clonal. So that's a fairly simple idea. But how powerful that idea is, because you see that in a single case if you're a molecular biologist and you begin to think this is very, very clearly causal, right? So here we tested just 10 tumors. 7 of them were positive for the virus. 6 of them were clonally positive for the virus. Each and every tumor cell had one individual integration event in each tumor cell, right? That's pretty weak beer to an epidemiologist. I think a case control study with 10 cases, who's going to believe that? But among molecular biologists, or at least molecular virologists, if I show this data to them, they're absolutely convinced that this is a causal event, at least among these 6 tumors that are clonal. So here's a case where epidemiology is not necessarily relying on data that molecular biologists are presenting, and molecular biologists are seeing something very different from epidemiologists. Now, this is held up. Here are the 8 cases we originally looked at, and now there are over 2,300 cases that have been looked at worldwide, and it looks like about the same rate of positivity is there. About 80% of Merkel cell tumors are positive for the virus. Roz, you're going to let me know when I'm going over, right?
I'd say a couple of minutes.
A couple of minutes. Okay. So now we have a precise molecular pattern, a molecular pathology for this tumor, in which we believe that children, young adults are infected with this virus. It lives with us as a as part of our skin flora. It is and these are asymptomatic infections. People who get these infections are not at higher risk for cancers. However, if you become immunosuppressed and you lose a specific level of T cell surveillance for this virus, the virus starts to replicate. When it starts to replicate, there are replication intermediates that break apart, will reintegrate into the host genome, or perhaps exogenous mutagens like UV light may damage the DNA of the virus, causing integration of the virus, and you'll have an integration event within the host chromosome. But that isn't sufficient to cause a tumor. In order to cause a tumor, we know that you have to have a very precise mutation within that T antigen gene that eliminates the ability of that virus to replicate its own DNA, reasons I won't go into. But what this tells you is that while there is nearly 100% infection, at least 80% infection of people in this room, very few of you have this combination of probabilities in which you have a specific loss of T cell surveillance plus an integration event in your host genome plus this mutation in the virus in the correct spot in order for you to develop this tumor. You can't really get at that through epidemiology. That's a very molecular biologic approach. Now, I wanted to just show this to say what can we do with, I certainly don't want to be an apologist for the Human Genome Project, but there are some good things about it. In this case, we found using human genome data not only the virus itself, but also we found one specific cellular gene that the virus induced that encodes a oncoprotein called survivin. Turns out that there is a small molecule inhibitor of this protein. And when you give this, it's called YM155. I'm not certain what's going to happen with this, but nonetheless, these are mice data and xenografts where we take Merkel cell tumors, put them into mice, and then treat the mice. These tumors are extremely resistant to chemotherapeutics, but we see there is at least one specific inhibitor that is based on a molecular pattern that we see based on the human genome data that looks like it's very precise and promising for treating these tumors. That was my 1 minute. I'm just going to end here. I'm actually not going to talk about the good stuff. But I do want to, so if you're disappointed, so what? No, I'm sorry. So I do want to end with this, just to say that when I was in medical school, I was taught that there were two polyomaviruses, JC virus and BK virus. Since they're then using molecular techniques, there have been at least 9 other polyomaviruses, all of them carrying T antigens, all of them being common flora in our skin, in our guts, in our bloodstream, and all of them at least having potential to cause tumors. And so epidemiologists now will have to work with these very common but previously unseen molecular signatures from these viruses and try and tease out what are the epidemiologic clues that we have to look at in order to determine causality. I'm going to stop there rather than go on just so that we can give the other speakers a chance. But thank you very much for your attention.